All right, let's get going. I don't want to take too much time away from our presentations today. Good afternoon. My name is Kristen Paulson. I'm the Chief Operating Officer here at the Center for Improving Value in Healthcare. And I wanted to welcome you to our Data to Drive Decisions. Today, we're focused on COVID-19, research revealed, mental health as a predictor of illness, and the health impacts of long-haul cases. Next slide. So a few housekeeping matters. All of the lines are muted. We're going to be managing questions today through the chat box. So please use the chat to submit your questions. If they have to do with the immediate presentation, I will make a note to the presenters and try to address it then. Otherwise, we'll be addressing questions at the end of the presentations and having a discussion about the two programs you're going to be hearing about. This webinar is being recorded. Both the slides that you're seeing and a link to the recording are going to be posted on the events resources page at CIVHC.org. That should happen in about the next week. So keep an eye out for those and feel free to take a look. So our presenters today, we have Dr. Thomas Wilson from Trajectory Healthcare and the Population Health Impact Institute, Jesse Sullivan, who worked with Dr. Wilson on one of our presentations, and then Isabella Chu, the Associate Director of the Data Core at Stanford. So a quick overview of our agenda. We're going to do a brief overview of CIVHC and the Colorado All-Payer Claims Database before handing things over to Isabella Chu to present on COVID-19 real-world data, looking at causes, inequities, and risk for death and disability. And then following Isabella, we're going to be passing it over to Jesse Sullivan and Tom Wilson to talk about their examination of predictors of COVID-19 diagnoses, followed by questions and discussions for the group. So here at CIVHC, our mission is to empower individuals, communities, and organizations to advance the triple aim of better health, better care, and lower costs using collaborative support services and healthcare information. We are a nonprofit organization, we are independent, and we consider ourselves to be an objective supporter of the triple aim. We serve a variety of stakeholders across the country, including clinicians and hospitals, government, policymakers, employers, nonprofits, health plans, and researchers. All of those individuals hold the consumers as our central focus. We want to improve the health experience for consumers overall. Next. We do that through a number of different mechanisms. So on civhc.org, you'll notice a wide variety of public Colorado APCD data to identify opportunities to improve the health in your community and across the state. This includes both high-level analytics, deep dive interactive reports, and downloadable data sets for you to use. And then we also have non-public Colorado APCD data, which allows individuals and researchers to license specific data from our very comprehensive claims database to address their specific research concerns. Thanks. Just a snapshot of what's in the Colorado APCD. A vastly more in-depth look at this is available on our website under Get Data, what's in the Colorado APCD. Our database currently has over 700 million claims. Actually, if you use our archive data as well, we are at or right about 1 billion claims that represent a total of almost 8 million distinct people across the APCD and 44 different payers. Again, if you head to this link on our website, you'll be able to get a lot more granular information about what is contained within the Colorado APCD. All right, well, I'm going to hand things over to Isabella Chu to walk through our first presentation.
Good morning, everyone, if you're on the West Coast, or afternoon if you're on the East Coast or somewhere in between. So today I'm going to talk about a grant that we had proposed to the NIH, and then it was kind of split apart into several other projects after sort of review of that. And basically it's looking using real world data to better understand COVID, the epidemiology of COVID, its trajectory, treatments, vaccination, and another issue that's arisen during the last 2 years, which is a large spike in all-cause mortality. The next slide, please. Um, oh, it's like a shadow. Interesting. So this is, oh, there we go. So this is our center. So we've, early on in the origin of our center, we made a huge investment in kind of R&D and tech to host high value, high risk data. And this means that a core team of a fairly small number of people is able to administer those data sets and keep them secure. For individual projects, we typically hire a number of analysts, but this is our core team, and our faculty director is David Rakoff, who's a social epidemiologist. And then we have a number of data managers. Next slide, please. Our approach to population health is really looking at the impacts of real world data. There are many other kinds of data that you can use to study health and interventions, but our center is really chosen to focus on real world data, and that's for a couple of reasons. Next slide, please. The first is, so there are three types of data that centers like ours would typically use. The first is randomized controlled trials, and these are fantastic for things like drugs, as you all know, because they deal with a lot of the things that you would find very hard to control for if you can't measure it. Traditional cohort studies, and we also have relationships with a number of those. But again, going back to the reason we've really chosen to focus on real world data, and particularly data sets like all payer claims or the Colorado all payer claims, is because they deal with a lot of the biases that are inherent in the other two kinds of data. The kinds of people who sign up for studies, and particularly studies that go on for years, tend to be very different than the kinds of people who don't. And so, you know, drugs almost always perform better in studies than they do in the wild, all kinds of things like that. It's very hard to reach certain populations. And so one of the things we were so excited about, and we even have other claims data sets, but one of the things we were so excited about with the Colorado all-payer claims data set is that it really incorporates all sort of socioeconomic strata and is much more representative of the population than, say, a claims data set you purchased from one holder. So that was really our reason for partnering with CIVHC on this project. Next slide, please. So when we think about what makes data useful, and I know I keep coming back to this, it has to be several things. It has to be large and representative of the population from which it was derived, and the Colorado all-payer claims certainly meets that criteria. Longitudinal, so, you know, particularly in population health, you know, exposures can often precede diseases by years, even decades. And so the ability to follow people over time is incredibly important. And this data set also provided the ability to do that because people tend to stay in the same state, at least for a few years, and linkable. And there are a lot of ways to do linkage which preserve privacy, confidentiality, and security. And there are a lot of really innovative techniques, hashing, you know, encrypted keys, that kind of thing. And we incorporate a number of different strategies to make sure that these linkages, while adding new research insights, don't increase risk, re-identification risk, or privacy or security risk. Next slide, please. So the aims of the covered project are pretty simple. We want to look at the incidence, prevalence, course, and outcomes of COVID-19 and the variants. The efficacy and equity of the distribution of the COVID vaccines. And again, working with a state is particularly helpful for that because the vaccine registration data is typically held at the state level. And so, you know, kind of matching it with a state APCD is probably the best way to answer that question, as it's taking a while for that data to get into EHRs and claims. And finally, long haul COVID. This has been a real problem. You know, I'm sure you're all aware that there are very high incidence of long COVID. And again, the longitudinality of these data really allow us to follow these people to see how they're doing, what the long-term trajectory is. And then finally, there's a real concern. So over and above the COVID deaths, there's been this 20% spike in all-cause mortality. And, you know, there have been a number of papers about this at this point, but we really want to understand what's driving those extra deaths. to inform when interventions can sort of help reduce all-cause mortality. And, the next group is going to talk about mental health, things like that may actually be explaining this, or they could be uncounted COVID deaths. We're not sure, or a number of things. Next slide, please. So the data set that we're using in conjunction with the CIVHC data is called the American Family Cohort. And this is an EMR data set in about 6.5 and close to 7 million patients now from 3,000 practices. And so by combining these data in a secure, encrypted way with outside data sets, we're able to get a complete picture of the patient. And to give you an example of the kind of biases that can be introduced when you don't do this, we have a claims data set, and in that claims data set, African Americans do better than white patients. And so without a complete picture, you can often get the wrong answer. And so we're really excited to be able to look side by side at these data sets and get insights into COVID. Next slide, please. So this is extremely preliminary work we've done with this data set in partnership with the CDC. We're the data set that we have, the AFC, is disproportionately rural, which are individuals that are typically or often not included in other sorts of EHR claims data sets, although that's getting better. And so we use the ILI and COVID-like illness to sort of map COVID rates early in the pandemic before there were tests, especially in these rural areas. And even now there can be test shortages. So we're trying to use sort of a symptom-based profile to track COVID incidence in rural areas. Next study, please, or next slide, please. So that's it. That's our planned work. We do have a grant with CDC to study this, and we're excited to work with both Colorado and the American Family Cohort to get insight into the latest COVID waves, how the vaccines are playing out, and the increase in all-cause mortality. Thank you.
Thank you, Isabella. Now, before we move on to our next presentation, I do want to point out that yesterday there was an NPR article or discussion talking about a CDC recommendation to recognize mental illness as a risk factor for COVID. So that's just sort of to preview and set the stage for our next two presenters. I'm going to go ahead and put the link to that article in the chat box so folks can access it when they like. But now I do want to turn things over to Dr. Tom Wilson and Jesse Sullivan so they can walk through what they have been looking at using the Colorado all-payer claims data in COVID-19 analyses.
Thank you, Kirsten, and a great presentation, Isabel. Yeah, we've actually used the Colorado data set to come up with some conclusions, and we're going to talk about that. It's really from the first wave of the epidemic, and we find that the Colorado All Payers data set, we call it a real treasure for exploring real-world data population. Next slide. So what we're going to do is talk about population health, public health, how these are related and how they're different, and then how they both differ from clinical medicine. We'll talk a little bit about the Colorado All Payers claims data set and how we used it, unique challenges that we see in doing population health studies. And then Jesse's going to go over the methods and findings of our real world study, which were predictors of the initial COVID-19 diagnosis. And then we'll briefly talk about next steps. Next slide. I think what I've seen in my career in academic and then as an independent consultant, there's a real dichotomy almost between what people think of as healthcare, clinical medicine, and what population health is. And I've sort of come to this conclusion that in general, clinical medicine has an N of 1. In other words, my doctor and me have a relationship, and he diagnoses things in me and treats me and gives me the recommendations, and the N is 1. Whereas in population health, the N is greater than 1. And it's a huge difference, actually, because we're looking at more than one person. The intervention can be on individuals, of course, but can also be on groups, like an individual intervention could be an immunization. A group intervention could be a sewer or an immunization campaign. In fact, the first great achievements in public health were sanitary sewer systems. The measure of the impact in a population health study is on a defined population, which are, of course, made up of individuals. And these could be examples of these could be employees at Vail resorts with hypertension, or the public at risk for COVID-19. And importantly, the recommendations, the findings and recommendations of these population health studies, of course, can be presented to the individual, but in general, they're presented to what I'm calling the governance of the defined population, the board of directors of Vail, the legislature of the state of Ohio, et cetera. Or, it's a different dynamic there. And what's important is both clinical medicine benefits from population medicine and population benefits from clinical medicine. In fact, a lot of the interventions we do in clinical medicine today are from population health studies. We apply the findings of the group in the population to justify an individual intervention. And some people call this precision medicine. So there is a dynamic, an important dynamic between these two types of health. Next slide. And now Jesse is going to, we're going to do a tag team here. So Jesse is going to talk about claims data. Go ahead, Jesse.
Yeah, thank you, Tom. So both Isabella and Tom talked about the value of claims data and research. And I just want to echo from my own experience that clinicians are often very distrustful of claims data, which is often less precise than data at the, collected in the laboratory or at the bedside. But it often takes a very long time for findings from clinical research to make their way into practice. And as Isabella had mentioned, there's often a real difference in the results in the real world compared to the clinical study. And because of this, consequently, clinicians, regulators, payers all worry about translating research into practice. And so it's just, we think it's sort of, our study is coming from the other direction, that we have used claims data to translate what has already happened in the real world into research for a better understanding. Next slide. Back to Tom.
Okay, and I think what I've also noticed, and I had to learn this, there's a lot going on in health. It's not just medicine, it's not just medical care, although that's where the vast majority of the dollars in healthcare go. What I've seen in this current pandemic is there is conflicts between the individual and the group, and and both the individual and the group. I mean, this is a central issue that we have in a public health pandemic. Public health officials often say, follow the data. Well, I work with data all the time. What is data? And I think what they mean is follow the population health data, the group findings. 90% have this, 30% have this. It seems to put the group over the individual. And I have relatives who don't like this. They find this insulting because we're America. We're based on individuals. People are insulted by it. And I think a lot of the public health officials didn't really get this. Dr. Amy Acton, who I physician and a public health person, and early in the epidemic, she was the head of the Ohio Department of Health, said this in a newspaper article, and I love this quote: as a doctor, as a scientist, I was not aware of the things that set off those triggers, emotional triggers for people. People, as you know, have been up in arms against some of these public health recommendations. So health is a big deal. The World Health Organization defined in the 70s what health is. And this is a quote from their Alma Alta Declaration. Health is a state of complete physical, mental, and social well-being, and not merely the absence of death or infirmity. Health requires the action of many other social and economic sectors in addition to the health sector. So it's not just medicine, it's a whole bunch of other stuff. It's a team sport, sociology, politics, business, history, engineering, law, and yes, epidemiology and medicine. And Jesse and I are representatives of two of those disciplines, epidemiology and medicine. So I think this is the start of collaborations that we need. And nobody's in charge of this. We work collaboratively. So it's a start. Next slide.
Thank you. So I first met Tom when I was the chief medical officer of a New York regional Medicaid managed care plan. And Tom helped me to use claims data to evaluate a costly intervention. So early in the epidemic, Tom reached out to me and said he had obtained some claims data and was interested in looking at the relationship between mental health and COVID, and would I like to collaborate with him, and I was eager to do so. So we had an initial discussion about what would be interesting, and we were very interested in what the impact would be on the mental health of persons who had a COVID infection, and also what the impact of the epidemic itself, the deprivations and the disruptions of the epidemic had on people in general, even if they didn't have a COVID infection. But the initial data set that we had just included the first part of the epidemic through June of 2020. And so we really did not know what we were going to find, but we realized with that timetable, what we could look at was what impact was there of a prior diagnosis of mental health on the risk of getting a COVID infection, and that's what we looked at. And this is a reference to the preprint that we submitted in March of this year. So next slide, please. So when you're looking at the results of a study, it's really important to ask the question, compared to what? And so we wanted to compare COVID patients to persons who were similar but did not get COVID. And so what makes someone similar? So the size of the Colorado data set allowed us to use the technique of I'm looking for it. Tom, help me out here.
Propensity score matching.
I'm just blanked. Propensity score matching. So we use propensity score matching in this data set to select a comparable comparison group. And so the things that we wanted to look at, well, the first thing we needed to do was to find a comparable index date. And for the patients who got COVID, we used the date of their first primary diagnosis at the month as the index date. And then in the group of patients who didn't get COVID, we looked for someone who had had any healthcare service in that same month. And so that's how we matched on index date. And we wanted to look at people of comparable sex. So we looked at male and female, and comparable age. And for age, we looked at persons less than 30 years old, those between 30 and 64, and those greater than 65. It was really important that we look at people who had a similar health status. We didn't want to compare healthy people to sick people. So what we decided to use to estimate that was the quartile of health costs in the 12 months prior to the index date. And that was based on an assumption that someone who has very low health costs is probably generally in better health than someone who has very high health costs. And then finally, because we were using a claims data set, we needed to ensure that we were aligning on the length of enrollment in insurance. And we estimated that by counting the months between the index date and the first claim in the data set in the 12 months prior. And then after we did our initial study, and I'll talk about this later, we went back and added a measure of social determinants, and we used Medicaid status. The next slide. So this is a very busy slide, but what this shows is that we successfully used propensity score matching to create a appropriate comparison group. So in each of these plots, the bottom two bars show the population that did not get COVID compared to the COVID population across the entire data set. And then the top two bars show the population who got COVID compared to our selected comparison group. So in this first section on the upper left, it's by age band, and you can see that compared to the COVID patients, the non-COVID patients who are at the very bottom were an older group. And that makes total sense. That's what we expected. We saw that older people were impacted more by COVID. But when we use the propensity score matching to select from that total group, our comparison group, you can see that the upper two bands match very closely, and that the COVID patients match our comparison group. In the center, we have the comparison by sex, and there were very few differences. On the upper right, we're looking at the cost quartiles, and you can see that the COVID patients have significantly more individuals in the high cost band, and in the non-COVID patients, the cost bands are divided into quartiles because we divided them into quartiles. So from this non-COVID group, we selected our comparison group. So that in the upper two bands, you can see that the COVID patients match the comparison group very closely. And in the bottom left, we looked at the index month of service, and the very bottom band shows that that non-COVID patients continued to receive health services during the month of March, but that by the time things began to shut down, people who were healthy were not going to the doctor very often. Whereas among the COVID patients, there were very few COVID diagnoses in March, but then there were more COVID patients seeking care in April, May, and June. And then finally, in the lower right, we looked at the estimated duration of health insurance coverage. And generally speaking, for all before and after our matching, most people had 11 or 12 months of coverage. But there is one little anomaly here, which is that among the COVID patients, there were a disproportionate number of people who had less than 1 month of coverage. And that suggests that there were some persons who were initially enrolled into insurance coverage when they had COVID. And I don't know exactly how that would work in Colorado, but I know that in New York, if an uninsured person was admitted to the hospital with no insurance, they would be enrolled in emergency Medicaid and would then appear in the insurance claim data set. So I suspect that might be what it means. So when we were done with this analysis and we had our selected group, there were 554 COVID patients who did not have a good match. And so they were eliminated from the data set. And our data set, our final data set included 7,599 patients with COVID and 7,599 patients who did not have COVID. And you can just see here at the bottom that before we did this, there had been 8,153 COVID patients. So we eliminated 500 patients. Next slide. Oh, that's all our animation, going through what I just said. So this slide shows our results. The blue bars represent the findings of our initial study, where we were looking at the effect of a prior diagnosis on the subsequent risk of a COVID-19 diagnosis. We found that a prior diagnosis of a mental or behavioral health condition, the bars on the left, was an independent risk factor for getting COVID-19, and that risk was similar to that of known other health conditions which were considered risk factors for COVID. And so we posted these results and we gave a webinar on our results, and we obtained some feedback at the webinar, particularly from my colleague, Dr. Deborah Viola, who who raised the question of, well, she said, we know that that people on Medicaid people with serious mental health problems are disproportionately enrolled in Medicaid. And how do you know that that isn't complicating your results? And maybe the mental health results are a result of that confounder. And so we thought that was a very good point. And we wanted to add a social determinant of health metric to our model. And so we used Medicaid coverage as a proxy for low economic status. And then we redid the study, and the results of that second study are shown with the orange bars. And on the far right, you can see that Medicaid insurance alone was a very significant independent predictor of a COVID-19 diagnosis. However, in this model, when we included Medicaid status as a variable, a prior diagnosis of a mental or behavioral health condition continued to be an independent predictor, independent of Medicaid status for a COVID-19 diagnosis. So in conclusions, we have three conclusions. First, that patients with an existing mental behavioral health diagnosis were at increased risk for COVID infection. The risk was similar to that seen for other prior diagnoses such as diabetes, hypertension, and asthma. And then as was pointed out at the beginning, this was highlighted yesterday on NPR, a story about that the CDC had recently added mental health as a risk factor for those who should obtain a COVID vaccine. Our second finding is that disparities in health associated with social determinants, while generally recognized, we believe that our study really underscores the magnitude of this effect and the importance of including social determinant variables when doing healthcare research. And then finally, we think our study shows that claims data can be a valuable resource in the retrospective analysis of a healthcare event. So thank you. Next slide.
Excellent, Jessie. We were very excited yesterday. Jessie lives in New York. I live in Cincinnati, Ohio, where NPR was talking about what we had recommended 6 months ago, right? That mental health should be considered a strong risk factor for getting COVID. So that was very nice. What we're planning to do, is going forward with the Colorado data set when we get some funding, is to look at some more broader definitions of social determinants of health. For example, using the area deprivation index, rural urban status, and other things. And I'm doing another project with another client on this very thing. And one thing we always have to be concerned about when we use group level data on individuals is to make the assumption that that group level metric is actually a good indicator of the individual person, right? And it often is, it often is not. And we often really don't know what the answer is. We call that in epidemiology, the ecological fallacy. There's been a lot of discussion in the last year or so, and this is an ad, is your zip code more important than your genetic code? Of course, your zip code is a group level metric, and your genetic code is an individual level metric. So we think zip code may be extremely important, but we always have to be aware that we may be making a mistake in attributing group level information to individual people. I mean, that's called prejudice, right? So we got to be careful. So anyways, by the way, some of the physical risk factors we adjusted for were chronic kidney disease, asthma, hypertension, chronic obstructive pulmonary disease, and diabetes. And I just wanted to make that point. So we felt we did a really nice study. One thing that I made note at the beginning is that a lot of what we call health care is actually disease care. It's after people get sick, right? And that's where most of the dollars go. And we think it's important that there should be more funding for public health, for population health, for understanding what's going on, and perhaps preventing things from happening rather than waiting till they happen. So I know that's a standard mantra of public health people, but we just wanted to make that Next slide. This is just the contact information for Dr. Sullivan and myself, and we really appreciate the opportunity to present today, and we look forward to further collaboration with CIVHC. Thank you very much.
Thank you so much, Jesse and Dr. Wilson. So I'd like to open it up to some questions and discussion. We have the chat box open for folks who've got questions for any of our presenters today. As we're waiting for some of those questions to come in, I might start things off a little bit, kind of piggybacking on some of the conversation or some of the things you were just saying about sort of the importance of the social determinants in this larger disease analysis. So I'm actually going to start with Isabella. Can you talk a little bit about which elements, or have you identified which elements of these social determinants or non-direct medical influences you're going to be addressing as part of the equity focus of your long haul COVID analyses?
Sure. So we're going to take a few different approaches. We just recently got like last week, got a grant from RWJ. And so there are a number of what's called small area measures of social deprivation. And basically I think they usually use census tract. So these are pretty small areas. And then they incorporate a number of different factors: race, income, access to green space, there's all kinds of things you can incorporate into these measures. And they turn out to be pretty predictive of how people do. And so what we did was we got a grant, and there's something called the Federal Statistical Research Data Center. And it's basically a Fort Knox of data for census data. And the census now has a program to link census data to health data. And these are, done using hashed keys. Nobody has access to identifiers. But it allows us to really look at these social determinants of health at the individual level. And so this grant is going to be doing a head-to-head and say, okay, when you incorporate things like income, race, access to green space, access to healthy foods, particulate matter, that's an environmental exposure. It's not really social, but like when you incorporate all these things into an individual level measure, how does it stack up against a small area measure? And our prior is that if you're a high, and actually Raj Chetty has done work showing this, above a certain income threshold, it kind of doesn't matter where you live. As long as you're making money, you can kind of buy your way out of social deprivation and you're not socially deprived. However, if you're a low income person, and his work showed a huge effect size that can live in a area with a low social deprivation index and in a wealthier, more prosperous area, it has huge impacts on health outcomes. And it also actually impacts things like life expectancy, income at the age of 26, probability of finishing college, probability of having children after family formation, all kinds, pretty much everything we know how to measure. These small area measures are predictive, which is a really long-winded way of saying, we're going to do a deep dive and try to figure out which aspects of those individual level measures are most powerful. My prior would be it's probably income, but we don't know that. It may be education. It may be, who knows? And so we'll probably incorporate all of the things in those indices into our model and stack it up against and use probably the individual level or the small area. That was probably a much longer answer than you wanted, but.
No, I think that's great. Jesse and Tom, do you guys want to talk a little bit about, I know you mentioned some of the directions you're hoping to look for social determinants. One thing I would wonder a little bit on your side is, since we know some of the specific social determinants actually are correlated with higher risk for mental health diagnoses, is there some way you're hoping to be able to parse out sort of direct impact of the social determinant elements and just sort of pulling apart that, correlation between increased mental health diagnoses and some of these social determinants? Or is it just going to be sort of a combination influence that we can't really pull apart, do you think?
Well, I'll say just a broad issue here. I think one of my positions here is that it's not just COVID where mental health is a major risk factor. It's a major risk factor across the board. And it doesn't get the attention it should be getting. And one thing that we want to do, and I am doing, is looking at, I think we do live in a for-profit world for the most part. Insurance companies are generally for-profit entities. And I know, even if they're nonprofit entities, they want to make money. They want to have more revenue than cost. That's just the reality of our world in America. So I think it's really important to make a business case for mental health intervention, not just a social case. So to say, if we would focus on mental health care, improve mental health care, we could probably reduce the cost of physical health care. And I've done a couple papers on this. And I think we're planning to use the Colorado data set to help us tease out that question.
Great.
And, you know, I know Jesse is very interested in full population-wide metrics, which was really important. But what we did in our current study is we did a causal analysis. Basically, we controlled for as many things as we could, right? It wasn't a representative sample of Colorado at the end. It was a structured, it was as equivalent as we could get to a randomized controlled trial. So we could tease out the effects of mental health. And we think we made a really good case that is really, really important. So, you know, I endorse the Path Forward movement and other things too. And I'm working with some employer groups who, in their hearts, they know mental health is a huge contributor to healthcare costs. But there's not enough healthcare, there's not enough mental health care workers. Telehealth, I think, will be a major help there because you can reach out. So, so that's why I just wanted to make the big point that we don't necessarily have to tease it all out. We want to make people aware that it is a really important issue. And if we can help make a business case for mental health care, these for-profit health insurance companies will make the investments. You know, you don't have to pull at their heartstrings. That doesn't work that well.
Pull at their pocketbooks.
Pull at their pocketbook. Make the business case. So that's one of the things that we plan to do. Jesse, do you have anything to add?
Well, I was just going to add that, you know, the question that you asked, Kristen, wasn't really the question we were asking. You know, we really weren't looking at mental health. We were looking at COVID with mental health. But I just wanted to point out that a claims data set like the one you have is a very good resource for looking at the question that you asked, which is, are patients with a mental health diagnosis concentrated in the Medicaid population? So we didn't ask that question, but you could certainly look at that question quite easily in your data set.
Yes.
So we do have a comment in the chat box from Marcia Marshall, commenting on, you know, that we have a population of folks with serious mental illness, and that we know that getting them into Medicaid and into a medical home can be supportive. I was wondering, have you guys looked at, or are you planning on looking at sort of the difference between the severe and persistent mental illness diagnoses and other mental health diagnoses to see if there's a differential in the risk factors for
We
COVID-19?
definitely will plan to do that. We couldn't do it this time. We didn't have enough people. But in the ICD-10 coding system for diagnoses, there are in the description of each diagnosis, the word severe appears. And I've worked with some other groups where we've actually used that to differentiate severe mental illness from normal mental illness. And that would be definitely part of our next study. I mean, there's going to be, next study, this time we had 8,000 people. Next study we'll have 3 or 4 or 5 or 6 times more than that. We'll be able to tease all that stuff out. By the way, in our initial study, we did look at different diagnoses, didn't we, Jesse?
Yes, we did look at the.
You want to talk about that? We didn't do a statistic, you know, it wasn't powered basically to look at all these different diagnoses. but do you recall?
No, I'd have to pull it up again. Sorry.
But it's been a while. But we listed, if you pull the paper down, we can list the distribution of various diagnoses in people that had COVID versus people that didn't have COVID. And
well, and what I do recall is that schizophrenia, which would be a diagnosis that you would expect to be seen associated with FMI, was one of the higher risk
that's right.
subgroups. So that would
we'd be happy to follow up with
that would hold up.
But we can follow up for. We're happy to bring in new people to help us on this project. So.
All hands on deck.
Yep.
So following on that, I think these next few comments are kind of related. So Marcia Marshall also pointed out that these private for-profit health insurance, generally commercial health insurance, they're not really interested in patients who've got those severe mental illnesses. That's not really where their focus is, because those folks are very high intensity and can be high cost. And connected to that, Isabella just mentioned, are there estimates on the fraction of individuals with moderate to severe mental health that are uninsured? We do know that there is a higher proportion in the uninsured population than there is in other populations, and that the population in Medicaid is also increased. So this might, going back to your pocketbook comments earlier, and making the business case, how would that translate to making the case for Medicaid to have increased focus and increased dollars sent to protect or ensure these folks have access to healthcare?
Well, I can mention something about that. I mean, I don't know the whole big picture, but I know something. I know New York, and I know a little bit about Colorado from friends who are there. So it is true in both those states that someone who has severe persistent mental illness would eventually qualify for Medicaid, and they would have more comprehensive coverage under Medicaid than they would have under private insurance. And so there's a natural migration in the history of someone who has a severe mental illness to move from commercial insurance to Medicaid. So I don't know if it's quite accurate to say a commercial population doesn't care. I think it's that those folks are concentrated in Medicaid because that's what happens over the course of that illness. And I know that for New York, that population represented a huge proportion of the Medicaid costs overall. Actually, I think it was the 80-20. So an extremely important population for states to address with their Medicaid populations. And I don't think there's probably any state that isn't aware of that and conscious of that and thinking about that. So I think there's a lot of interest in what actually works to improve health and outcomes for that population, but with a focus among state Medicaid plans.
I'd like to make a couple comments. One, the questioner said commercial payers aren't interested in mental health. I don't think that's correct. I think, first of all, if an employer group signs up with an insurance company, they have to accept everybody. So there's not discrimination. It's illegal to discriminate. Right? So I think there is a problem in what they call parity. I think there's less. The level of money spent on mental health is less than physical health. About a year and a half ago, I worked with a foundation called the Bowman Family Foundation, and we did a study of the entire United States looking at the relationship between mental health and physical health, and saw a strong relationship. And again, I think that if we could make the business case to these for-profit companies or the Medicaid companies or the governments, the legislatures in the states are also very interested in reducing the cost of care of Medicaid. We can make the case that by focusing on mental health care for severe mentally ill or the less severe mentally ill, will reduce the cost of care for diabetics and people with COPD and hypertension. And there's a lot of evidence that this could probably happen, that they would do it. and I mean, I've done some work with the Kennedy Foundation, Patrick Kennedy's group. You know, they're advocates for parity and all that, and it's wonderful. We should have more mental health care, but in this country, it's the way you're going to get action is to show people they can make money by doing something. I mean, that's just the way it is, right? And so that's what. So we hope to help make that case in our subsequent papers with your data set.
Kristen, I saw that Ms. Marshall just posted something else about medical homes and behavioral health, and I just wanted to comment on that. So the last 5 years, I was working on a DISRP project in New York, and we did do some work with that, and it's extremely complex. So we found that a lot of patients with severe mental illness received no primary health care. They went to their behavioral health provider, and they did not, even if they were assigned and given a primary care provider, they didn't go. And we worked on a number of projects that sought to create better linkages through that. One of the ones that was most promising was that we enabled a behavioral health provider organization to provide a Stanford course for patient self-management of diabetes, and to provide it in the setting of the behavioral health clinic, and with really kind of amazing results. But when our DISRP funding ended, it went away, which is often what happens. But we were involved in a number of other projects trying to get primary care doctors into the behavioral health clinic, or get behavioral health providers into the primary care clinic. And there are a lot of difficulties that have to do with how the systems are built and paid for that make integration difficult. But some of the best results we saw were in the settings of community health centers, where they actually did have both on site, and they were able to do better integration. But I agree that it's a complex problem, and it's structural in a lot of ways.
Part of Colorado's focus during our state innovation model was the integration of physical and behavioral health. The primary focus was integrating behavioral health into primary care settings. However, we did have a number of pilots with our community mental health centers where we actually had comprehensive primary care brought into the mental health centers to provide a medical home for a number of these individuals. But unfortunately, it was primarily in the urban areas, in the urban tracts, and there's much less access to that kind of integration once you get outside of the Front Range in Colorado. So because of some of the things you've just noted, the funding streams, but even the disparity in information protection between 42 CFR Part 2 and HIPAA. And so even the EHRs could not, it was very few EHRs that could actually provide integrated record keeping for those individuals. And that was something that they had to perpetually try to problem solve.
Right.
So, Bella, did you want to bring any other thoughts to that conversation?
No, I mean, I think this is not an area of expertise, although, again, going back to the example of Optum, where we see this result where people who would normally fall into a more vulnerable group with a higher risk have better outcomes. I would imagine, since health insurance is tied to employment in this country to a very large degree, or being a partner or a child of someone who has steady employment, that alone would select out of commercial claims. I mean, it's very hard to hold a job with a severe mental health issue.
I want to make a point about the uninsured. One thing we probably can't get from the Colorado all-payer data set is any information about people that don't have insurance. It's just, that's a weakness, and I don't know how you can solve that one, but it's just reality.
We can do sample weighting. And that's something we're undertaking, but that would give us sort of demographic stuff. It wouldn't tell us who's kind of falls into that middle category.
Right, I agree.
They have a mental health issue, but not enough to wind up on long-term Medicaid.
And that's something we've actually brainstormed or been brainstorming with the state for a number of years, trying to figure out how we might be able to get, even if it just at one point in time, even if it's just a point evaluation of what kind of folks are we seeing who are uninsured and continue to be uninsured? How can we track some of the uncompensated care or out-of-pocket care that's being provided to those who don't have a steady source of insurance? We've had some discussion with our rural health centers about literally manual tracking of those individuals and those costs, and then trying to integrate them. It's a very challenging issue, though, and one that we would love to find a way to get solved. So if you have any thoughts about how to do that, we are open for any possibility, because that is a challenge that we have had for a number of years. Well, we are wrapping up to the last few minutes here. Are there any other comments that our presenters would like to make before we close for today?
Yes, thank you for having us. This was fantastic. It was really fun.
Yeah, it was really, really great. And I think Jesse and I think Isabella too, we all see the great value of this data set. Like one way to think about real world data, it wasn't collected for us. That wasn't its purpose, right? Claims data were collected to pay bills. And, you know, I've done some work for years now with doctors, and claims data says, well, you have 15 high-risk asthma patients, and you give the list of names, and they say, oh, those aren't my patients. And we say, but you billed for them, right? Because at the end of the day, the doctors are billing. And so you think they would embrace this stuff. And I know I worked with a large registry of cardiac patients, about 500,000 people. And we have wonderful data on acute myocardial infarction in the registry data. But we want to look for long-term outcomes. So we use claims data for 5 years out to look at incidence of heart failure. And the reviewers complained about it. Why can't you use that registry? It doesn't exist. We have no choice.
Right.
And so they saw what we had done as a weakness. And I said, actually, it's a strength, because nobody had done a 365,000 people study looking at 5-year outcomes with heart failure. This has never been done before. The only reason we can do it is because of claims data. Right. So yeah, it's not perfect. It's messy. It's lots of problems, but it's the best we got, and it's very valuable. And so the paper finally did get published. So anyways, claims data is wonderful.
Thank you all. I appreciate you all being here and taking the time to talk through some of your work. To the rest of our audience, please, if you have any questions, reach out to info@civic.org, and we will make sure your question gets to the right person. You can also connect with us on Facebook, LinkedIn, and Twitter. And then the recording will be posted early to mid next week at the link indicated in the slide below. Thank you, everyone. Again, I appreciate your time, and I hope you have a great rest of your day.